but I want to go ahead and introduce Dr. Novak. She's one of our neonatologists here. She attended medical school here, and she also attended residency and fellowship here. And then we lost her for a few years while she went into private practice, and then realized that was just craziness, I think, and decided to come back with us. So she is here with us. She is currently the medical director of our Focus program. She's also the director of the NOW's New Mexico program. Wait, no, wrong person. I'm sorry. I went too far down. I'm sorry. I was like, she's not the medical director of Focus. She is the fellowship director of our fellowship program, and she's also our medical director for the developmental care program here. So please welcome Dr. Novak while she presents on hypoxic ischemic encephalopathy. It's a horribly long name.
Yes, it is. We're just going to call it HIE from moving forward. Kathy, can you see my screen okay on your side so I know everyone else can see it all right?
I can see it great. Thank you.
Perfect. Great. Thank you so much. Well, welcome everybody. I'm really excited to get an opportunity to talk about this. I talked with Kathy about presenting on this actually a couple years ago after we had seen a few babies sent to us that maybe would have had the opportunity to be cooled if they were sent to us earlier, but we got them a couple days into their life, and so we'd missed a window for treatment. And we're going to go through and talk about what HIE is and what the treatment for it is and the long-term effects. So our objectives today are to define hypoxic ischemia as a unique cause of neonatal encephalopathy, to recognize the antenatal and intrapartum risk factors associated with it, to understand the pathophysiology behind it, review the cooling criteria, and to really talk about some of the initial management prior to a baby being sent to a tertiary center for definitive treatment. And then we'll also review some of the complications associated with cooling. So neonatal encephalopathy is a really heterogeneous syndrome that at the core has central nervous system issues. And so when we talk about neonatal encephalopathy, we really mean a baby who has presenting with altered mental state, and they can exhibit a variety of symptoms such as an abnormal level of consciousness. These babies are often what you would truly call lethargic in an infant. You can see the picture there. That is a bit what these babies look like, a baby with neonatal encephalopathy. They can, because of their depressed level of consciousness, they can have issues with respiration. Oftentimes these babies are depressed enough that they do need to be intubated. They are going to have abnormal tone and reflexes. Often the tone is very, very low, and depressed to absent reflexes are common. They can be presenting with seizures, and then certainly they, as I mentioned, they can be apneic and needing to be intubated. However, when we talk about neonatal encephalopathy, there is really no universal definition because it's such a heterogeneous presentation. And so it can be difficult to determine what is actually going on. And part of that is because there are neonatal encephalopathy really is an umbrella term, and it can include a variety of different etiologies, from genetic and inborn errors of metabolism to infection. Trauma certainly can present as an encephalopathic picture. Perinatal stroke can cause a baby to look with an altered mental status. Any kind of antenatal event or brain anomalies, so a baby with holoprosencephaly or agenesis of the corpus callosum, these infants sometimes can appear encephalopathic at birth. And so again, this is a heterogeneous syndrome that really at the core is trying to decide to describe an infant with central nervous system dysfunction. And so under that big heading, we can have an infant who has a hypoxic ischemia. And that really is meant to describe an infant that has undergone a disruption of oxygen supply to the body. And so this is often an infant who's presumed to have a degree of impaired blood gas exchange that has led then to progressive hypoxemia and hypercapnia. And really, it's usually thought to be something that has gone wrong with the placenta, because the placenta in utero is doing the job of the lungs. It's responsible for gas exchange. And so if the placenta is not working adequately, or if there's been a disruption of the blood flow from the baby to the placenta, then the HIE results. It is a major cause of morbidity and mortality worldwide. It's upwards of 8 infants per live birth in developed countries. And in resource-poor settings, it is much higher, up to 26 infants per 1,000 live births in resource-poor settings. And the US kind of does fall on the low end of that, but still common. And so worldwide, of infants who develop HIE following birth, the death rate is actually quite high. It's 10 to 60%, obviously the higher end being in more resource-poor settings or infants who have had severe disease. But annually, around 500,000 plus infants every year will die due to hypoxic ischemic encephalopathy. And even if an infant survives, there is often long-term neurodevelopmental consequences from it. And when you look at the literature, it says it's a quarter of survivors. Anecdotally, I feel like it is actually much higher than that with the infants that we see back in our special baby, our NICU follow-up clinic. It does account for upwards of 1/3 of CP among children. It's often spastic diplegia that you'll see as a form of CP with these infants. But even if there's not been a long-term major disability, such as severe CP or severely decreased intelligence scoring, infants still often have a degree of cognitive function, and that can present in a variety of ways, from intellectual impairment. Visual impairment is often very common with these infants, and including cortical vision issues where the eyes are working and the actual whole visual system works, but the brain is unable to process what information it's receiving. There can also be memory and verbal issues. And then at school age, you can start to see problems with executive function, certainly behavioral issues, ADHD is common, and then really the ability to interact socially in socially appropriate ways can become problematic. And so it really does speak to the need for ongoing early intervention for these infants, and certainly, like I mentioned, school age assessment really needs to happen. And these infants do often require ongoing extra resources outside of the NICU phase. So determining whether or not a hypoxic ischemic event occurred, and that's what actually caused the encephalopathic picture, that can be challenging. And part of that is there's no gold standard for diagnosis. And we're going to go through in a bit here how we determine an hypoxic ischemic infant. And it's a multi-step process. And so part of the problem is there's no biomarkers or laboratory data that we can get that will definitively say an infant has had HIE. So the signs of HIE are non-specific, as we talked about, and some of them are subjective. So determining tone in an infant or APGAR scores, these are kind of subjective measures. You can have an infant that has had an hypoxic event, but the brain imaging is normal. And you can have an infant who's had a hypoxic event who does have very subtle long-term neurologic deficits, so not really profound deficits. And so again, it can make it challenging in retrospect to know actually what occurred. Also, the ability to time the insult with, or the duration or magnitude of the insult, it can be difficult. There is data that shows biomarkers, and with brain imaging, we think that this is an acute event that kind of occurred right in the immediate perinatal period. But again, there's often this question, was it antenatal, was it perinatal, was it intrapartum? Timing is actually important in the sense that it often has medical legal ramifications. So HIE is a very common cause. It's actually the most common birth injury claim, and it's one of the most costly medical malpractice suits. And often the claimants point to an antenatal event that caused this, and so something that maybe had been able to be prevented, but the literature is not as clear as that. And so we do believe that antepartum factors can contribute to this risk for HIE. This was a big case control study out of Italy. They looked at over 30,000 infants who were later diagnosed with HIE and then went back to common antenatal or antepartum risk factors. And what they found is they did find a variety of risk factors as being suggestive, but only a couple that were actually statistically significant. And so diabetes, hypothyroidism, pre-E or hypertension in mom, obesity, previous cesarean section, mom who's had a neurologic issue, no prenatal care, SGA, oligo, or polyhydramnios, non-reactive fetal heart surveillance prior to delivery, and were all, again, suggestive, but these were the three that actually ended up being statistically significant. And this in particular, the non-reactive fetal heart rate tracing, we'll see again and again as being suggestive of an infant who's at risk for HIE. But overall, only about a third of infants who do present with neonatal encephalopathy had any antepartum risk factor. And so certainly that alone is not going to be the etiology for all infants. About a quarter also had intrapartum risk factors, which we're going to talk about in a moment. And then overall, half had a combination of antepartum and intrapartum. But so again, that leaves 50% that there were no clues prenatally that HIE was going to develop. So again, intrapartum factors do seem to contribute. This was a retrospective study from pediatrics that looked at, again, cases and controls, trying to find common factors in the cases. And they did find that of infants who went on to develop HIE, they were more likely to have intrapartum factors. And these were the ones that were statistically significant. Premature rupture of membrane, abnormal tracing prior to delivery, thick meconium, a sentinel event, we'll talk about those in a moment, shoulder dystocia, a nuchal cord, or failed version, excuse me. And then when they looked at the antepartum factors, there were some antepartum factors that suggested risk. So certainly post-state infants or younger infants, a younger mother, hypertension again shows up, or a primate. But when they looked at multi-factor regression, it was only the infants that were post-states that showed to be really high risk from as far as an antepartum perspective. And so probably what really is going on here is that there's antepartum factors that can predispose a woman to experience an intrapartum event. Then an adverse intrapartum event occurs, and then the baby goes on to develop neonatal encephalopathy. And another factor that we haven't touched on yet is infection, or chorioamnionitis, really does seem to predispose infants when you add in some adverse antepartum factors and adverse intrapartum factors. If there's infection on top of that, that seems to put the risk even higher for infants. And that is probably because of the inflammatory cascade that happens in the studying of chorioamnionitis. So how do you know to worry about an infant? So there are some intrapartum events that really should start to raise the level of concern for HIE, or that HIE is a possibility in infants. So again, maternal fever or chorioamnionitis, poor heart rate tracing, fetal acidemia, any kind of assisted vaginal delivery, either an emergent C-section or, or assisted vaginal delivery, passage of meconium, because that's a sign of an infant who's had distress in utero. The passage of meconium often goes hand in hand with fetal acidemia, or a sentinel event. So in any of these scenarios should start to raise the concern that an infant's at risk for HIE, and that should be high on the radar once the baby's born. So a sentinel event is when there has been an abrupt or acute decrease in placental perfusion. And so that can be either maternal, uroplacental, or fetal. So a mom who's had cardiac arrest or shock. We've had several moms who have been recently with COVID on ECMO. That would certainly put you kind of in this maternal risk category. Uroplacental would be an abruption, cord prolapse, rupture, a tight nuchal cord, or again, fetal, so dystocia, twin-to-twin transfusion, cardiac arrhythmia, or fetal exsanguination. So any event that's going to impair oxygenation to the baby, perfusion, or both. And certainly if you see a category 3 tracing prior to delivery, this really should be indicative of fetal acidemia. And so again, the risk for HIE. And so as a reminder, category 3 tracing is a sinusoidal pattern or recurrent late decelerations with an infant who's had absent variability, with either late decels or bradycardia. So any one of these tracings really is ominous for an infant. So what happens? Why is decreased perfusion or hypoxia so dangerous to the infant? So when we look at the cerebrovascular autoregulation in an infant, most of the time infants are able to maintain in this area of the curve. So it's going to protect the brain from blood pressure fluctuations. So as pressure increases when you're in this part of the curve, the blood flow is going to decrease to kind of maintain continuous perfusion. But what happens at either end of the curve is you get to where you are pressure passive, and as on the far end of the curve, as pressure goes up, cerebral blood flow is going to go up, or if you get on the low end of the curve, as pressure goes down, cerebral blood flow is going to go down. And so then these changes on either end of the curve are going to affect the perfusion to the brain. And so what happens with hypoxia in an infant is you have this cascade of events that ultimately lead to excitatory problems within the neuronal cells and increased calcium. So you go into anaerobic metabolism, the sodium-potassium pump starts to fail. You have an increase in glutamate, which leads to an increase of calcium. And from there, you have a kind of a cascade that leads to cellular death. And there's kind of a known time frame that this occurs. So immediately after a hypoxic event, you have what's called primary energy failure. And that occurs within minutes of decreased perfusion or profound hypoxia. And so what you see is, again, the sodium potassium pump failure. You have an increase in lactate. this excitotoxicity and oxidative stress that then leads to cell death via necrosis. And then once the baby is out of mom and perfusion has been restored to the brain, you enter in this latent phase that really occurs within the first few hours following delivery. And this 1 to 6 hours is going to become important when we talk about treatment and why it's so important to have treatment within that first 6 hours of life. And that's because we're in that latent phase where the reperfusion is occurring. After that latent phase, you go into the secondary energy failure, and where you've had the ongoing cascade of events that's still occurring within the brain, and you really start to see effects from the huge amount of inflammation that leads to cytotoxic edema, and then you go on to kind of have this programmed cell death with apoptosis. And that occurs after the first 6 hours up through the first day of life. And then ongoing and latent, you get into days or months later. So you still have kind of cerebral atrophy that can occur. And so after a HIE event, you can kind of see, depending on the severity, differential outcomes. So if it's severe, like we'd mentioned earlier, infant death is not uncommon. If you have kind of a recovery from this initial cardiorespiratory event, you can go on to develop encephalopathy and then with developmental disability. This part right here, though, is what's most concerning, I think, is that you can have an infant who recovers and looks okay in the days following the event, but then still go on to have developmental disability down the road. Or, you know, in the more minor cases, you can have recovery and then a normal outcome. So we talk about a lot about HIE being a brain event or neurovascular event, but really multi-organ dysfunction is very, very common. And part of the reason for that is our bodies are really smart, and we have something called the diving reflex that when we have severe hypoxemia, we preserve the blood flow to the brain as best we can. And what then ends up happening, though, is all the other major organs take a hit. And so the severity of dysfunction to the other organs really does correlate with the severity of the HIV, and truly every major organ system can be affected. And so this was a retrospective study that was done with infants that were born in Spain. And what they did is they went back and looked at infants who had HIE based on severity, looked at what organ systems were affected and how severely affected, and then when in life it was affected. And so with infants, this is this gray up here is infants with severe HIE. So in infants with severe HIE, almost 100% had cardiovascular and respiratory issues that often persisted at least through day of life 3. But renal, hematologic, and then electrolyte disturbances were also common. And of all the infants did at least present with some multi-organ dysfunction on day of life 1. So when we talk about multi-organ dysfunction, like I said, really every single organ system for these infants can be affected. These are some of the sickest infants we'll see in the NICU. And so certainly starting with the brain, like we talked about, the heart, hypotension and bradycardia is not uncommon. We often will end up having these infants with need for pressors during the first few days of life to maintain their blood pressure. Respiratory issues are common, in addition to the infant having depressed respiration and apnea, like we mentioned earlier, and need for intubation. Persistent pulmonary hypertension is often seen in these infants. A baby with severe HIE will sometimes end up needing to go on ECMO for assistance with just heart and lung function. But then some of the organ systems that we might not immediately think about is liver, which I don't have a picture of here, but LFTs are often abnormal in these infants. Direct hyperbilirubinemia can be an ongoing problem, particularly if we've not fed the infant for an extended period of time. We do see TPN cholestasis develop, but it really stems from that initial hit to the liver. The kidneys are often affected with what we'll see as acute kidney injury, elevations in creatinine. Perfusion to the GI system is an issue. And so we often worry about these infants developing necrotizing enterocolitis because the decreased perfusion initially will put the bowel at risk. And then hematologic is a very common issue with babies who've undergone HIE. So we can see problems with coagulation and clotting issues, and then certainly thrombophilia is another common issue. So an infant who is at risk for HIE should be developed or should be recognized in the delivery room. So things that will clue you in is an APGAR less than 5 at 10 minutes of life, need for extensive resuscitation with chest compressions, certainly epinephrine use, need for ongoing PPV more than 10 minutes. And again, acidemia because of the need for anaerobic metabolism with the disruption of blood flow. So increase in your lactate, which is going to increase the risk for acidemia. So a pH less than 7 or base deficit more than 16. So how do you know an infant is acidotic? Cord blood gases are really critical for these infants. We, even at UNM, will run into issues with cord gases not being sent. And so if you don't have a cord gas available to you, certainly getting gas in the infant within the first hour of life can really be helpful. So 10-minute APGAR scores are associated with neurodevelopmental outcomes. The National Institute of Child Health and Human Development Research Network has gone back and looked to see if APGAR scores do correlate with long-term outcome, and the answer is that they do. So 3/4 of infants in one study that had a APGAR score of less than 3 at 10 minutes of life had death or severe disability, compared with 45% of those who had scores more than 3. And so for each point increase in your 10-minute APGAR score, that is significantly associated with lower risk for death or disability, and disability being an IQ less than 70. So yes, these APGAR scores do in the long term correlate with long-term outcomes. So we really do need to do a rapid clinical assessment on these infants to determine their eligibility for hypothermia, which is the treatment of choice. And so, as I mentioned in the beginning, this is kind of a two-step process to decide whether an infant should be undergoing therapeutic hypothermia. So the first is you have an infant in category A, who, as I mentioned, is acidotic, plus an APGAR score of less than 5 at 10 minutes and or the need for ongoing respiratory support, plus a category B, which would be moderate to severe encephalopathy on exam and or the presence of seizures. So you have to have the evidence of the acidosis with poor 10-minute APGAR score coupled with the exam. So it's this, I always say, qualifies you for an exam. The exam is what qualifies you for cooling. So two-step process. And this is the cooling exam criteria. So the Sarnay staging is used kind of internationally as the gold standard for determining whether an infant has a degree of encephalopathy severe enough to qualify for therapeutic hypothermia. And so what qualifies an infant is an exam in either the stage 2 or stage 3 category. So you look at different factors. So one is level of consciousness. The next is activity level, muscle tone, posture, primitive reflexes, autonomic dysfunction, seizures, and then it gives you your risk for death or disability. And again, it's these infants here that will qualify you. And you need at least 3 of the 6 in either the moderate or severe category to qualify for cooling. That doesn't mean these infants in the mild category are not at risk. As I mentioned earlier, you can have these babies who kind of appear normal at birth, but then do still go on for to have later neurodevelopmental impairment. It's just currently these infants don't qualify for cooling. There is some ongoing studies looking at whether these infants in the mild category would benefit or not. And we'll talk about that more in a moment. And so in the stage 2 or 3 category, these are really infants who are, again, they are lethargic or stuporous. They do have decreased or absent spontaneous activity. Tone is either hypotonic or flaccid. They are either in distal flexion, which I'll show a picture of here in a moment, or decerebrate. The primitive reflexes, you know, most term babies, if you stick your finger anywhere near their mouth, they're going to start to try to suck because of that strong rooting reflex. These babies will not have that. They'll often either have a weak rooting suck reflex, or they'll sometimes chomp down on your finger. So instead of sucking, they'll just bite on your finger. Moro is either weak, incomplete, or absent. Their pupils are constricted in the moderate, but dilated is more ominous. If an infant's in the moderate category, they'll often have spontaneous breathing, but it might not be regular. These infants are in the severe category, often need to be intubated. And seizures, we'll talk about in a moment, but more common in the moderate category, but are at least obvious. The severe, usually they're so obtunded, it's not obvious for seizure activity. So this is what the infant in distal flexion looks like. So, you know, a normal newborn should kind of be curled up in a ball. These babies will be what's called a frog leg position, with their legs bent and splayed out to the side. So this would be an infant who kind of looks to be in the moderate category. This is decerebrate posturing, where they've got their hands out to their side and their legs are straight. That would be more severe. And I've shown pictures kind of throughout of what floppy infants look like, but certainly if you have them turned over like that infant at the beginning and they're just kind of flopped over your hand, or you go to pull them up and they have significant head lag, that is a floppy infant. So to review, you have the baby with severe acidosis and then 10-minute of life clinical concerns, plus moderate to severe encephalopathy on neurologic exam, or seizures qualifies you for therapeutic hypothermia. And cooling really does need to be initiated within the first 6 hours following birth. And if you remember at the beginning, it's because that is when a baby enters that latent phase where an intervention really will make a difference, so that they don't go on and proceed to that secondary energy failure. And so hypothermia protocol is within the first 6 hours of life, you will cool an infant down to a temperature of between 33 to 34 degrees. That temperature is maintained for 3 full days, so 72 hours total. And then rewarming is done very slowly, and it should really not be more than 0.5 degrees Celsius per hour. And the reason for that is that when they've looked at infants who've been rapidly rewarmed, there is risk for seizure with the rewarming, or it kind of undoes the benefit of therapeutic hypothermia. If they're warmed too quickly, it can kind of cancel out the effect that you were hoping for with the therapeutic hypothermia. So I've talked a lot about therapeutic hypothermia. I want to mention it is the only proven neuroprotective therapy for treatment of HIE. So basically what you're doing is you're slowing down the metabolic process, and it allows the brain, because of the decreased metabolic activity, that it allows the brain time to recover. It is associated with decreased risk for death, neurodevelopmental disability, and cerebral palsy. The absolute risk reduction is about 15%. So not a huge risk reduction, but it is definitely a risk reduction. And then the number needed to treat is 7. And this is based on a Cochrane review that was done several years ago, where they looked at about 10 of the really big trials on hypothermia. There's also been shown to be a non-significant reduction in blindness, but a trend to decrease risk. And I do want to mention that the decrease in neurodevelopmental disability is really only seen in infants in the moderate category. Those are the infants that have been shown to have the most benefit from therapeutic hyperthermia. So again, even though the risk reduction isn't huge, it is better than what we had before, which was that prior to the advent of therapeutic hypothermia in infants in the severe group, they had universal risk of neurologic sequelae and about 75% risk of death. And so even though their neurodevelopmental disability isn't been shown to be significantly improved, in these big studies, there's been a trend to improvement. So we do think there's some benefit to these, even the severe infants. It's just not as profound as the benefit to infants in the moderate category. Another thing to mention is that when they've gone back and looked retrospectively at infants who have survived following therapeutic hypothermia, there's not been an increase in the rate of severe disability, meaning that we're not keeping more infants alive with higher disease burden. So there is clear benefit to cooling these infants. At 18 months following therapeutic hypothermia, when we look at the severe group, as I'd mentioned earlier, historically, it was about 75% risk of death. Following hypothermia, that's dropped down to 44% risk of death or major disability, again with severe CP or IQ less than 70. And that benefit is sustained. So when they followed these kids out to school age, there has been shown to be a strong correlation between outcomes at 18 to 24 months into childhood. So if you have mild CP or mild neurodevelopmental disability at 18 to 24 months, it's going to remain mild at school age. Unfortunately, the reversal is true, that if you have severe disability at 18 months, really, there's no improvement by school age. So if you're diagnosed with CP by 18 months, it's usually permanent. And there's been no difference, unfortunately, with some of these school age problems that we see with babies with HIEs, including low attention, executive dysfunction, and poor visual spatial scores. So again, really just speaking to the need for ongoing EI and school age assessment for these kids. So hypothermia works on several pathways to improve long-term outcomes. Like I said, it decreases the metabolic demand. So for every 1 degree Celsius decrease in body temperature, there's about a 10% decrease in cerebral metabolism. So again, slowing down that brain function allows time in this subacute phase for recovery. And so what you see is an improvement in the ion pump dysfunction that I talked about earlier, that sodium potassium pump dysfunction that occurs that allows this huge increase in calcium. That by cooling down the brain cells, it allows for recovery and decreased neurotoxicity. The free radical surge that happens following HIE is reduced with cooling, and then this pro-inflammatory cascade that I mentioned earlier, that's attenuated with cooling. So in this kind of subacute phase here, by making the brain cold, we are allowing time for recovery and a suppression of this kind of horrible cascade of events that affects the brain so profoundly. And it's relatively safe. So we do know that when we follow strict adherence to protocols, cooling is a safe treatment. The most common adverse event is bradycardia that often recovers with rewarming, but typically doesn't need treatment during cooling. It may worsen the thrombocytopenia that I'd mentioned earlier, but it doesn't seem to worsen any of these other multi-organ dysfunction events that we see associated with HIE. So these are going to occur regardless of whether the infant's cooled or not, and cooling doesn't seem to make it worse, other than the bradycardia and possibly the thrombocytopenia. Coagulopathy remains a problem, but that's a problem whether infants are cooled or not. There's two types of cooling. We have whole body cooling and selective head cooling. There have not been many head-to-head trials between the two, but they do seem to be equivocal in their efficacy. I will mention there have been people who have tried in lower resource settings to use water-filled gloves. That does cause some problems just because of the inability to maintain temperatures in a safe range. And it is important to use a servo control with these because it is easy to overcool. And so what happens when you cool outside of protocol? There have been studies, like I'd mentioned, currently we're looking to cool in the mild category to see if that improves outcomes. There's also work being done currently in a big NICHD study to see if cooling late preterm infants improve outcomes. So that data is kind of still out, but we do know that cooling babies longer or deeper is probably not safe. So there was a NRN study that looked at cooling for upwards of 4 days and to a lower temperature, which was stopped early due to safety concerns. There did seem to be more arrhythmia and longer hospital stays with the longer cooling. The deeper cooling, however, there was higher risk of INO use and ECMO, and then the group that got longer and deeper, there was actually higher mortality rates. So it does speak to the importance of cooling within protocol, and also really being able to ensure that infants don't get colder than you anticipated. And that has some impact on the question of whether or not to passively cool prior to arriving at a tertiary care center. We also know that cooling a little bit later may not help, but it might. So it's this study, there was no significant difference between the cooled and non-cooled group after the initial 6 hours. And again, because that 6 hour window and that latent phase of injury is so important, but there was a trend to decrease death or disability. So we sometimes will decide to cool infants after that 6 hour window because there is a chance that it might help. MRIs can help predict long-term outcomes. So the specificity and positive predictive value is pretty good for MRI. So if the brain is abnormal, at the time the scan is done, which is typically about 7 to 10 days of life, that portends a worse prognosis. However, the sensitivity and negative predictive value is not great. So if the scan is normal, it doesn't necessarily mean a normal outcome. And so we do have patterns of injury that are common with HIE. So in particular, patterns affecting the deep gray matter, the basal ganglia and thalamus, and then the watershed areas. And so the deep gray matter portends a worse prognosis. It's often associated with a more severe event or need for more vigorous resuscitation at time of delivery. It often is associated with poor motor outcome and severe disability. The injury to the white matter and watershed region in particular is a little bit of a better prognosis, but still highly associated with intellectual disability. Seizures are very common as a sequelae for HIE. The majority are subclinical, and it really speaks to the need to have very good surveillance with video EEG. Unfortunately, the rates for seizure between cooled and uncooled infants are very similar. However, the seizure burden is decreased with therapeutic hypothermia, and that's because the amplitude and duration of seizures seen on EEG is lessened with therapeutic hypothermia. And again, the biggest benefit to seizure reduction, and this is the theme again and again, is that in that moderate group, that severe group tends to have less benefit from therapeutic hypothermia. There is, as I mentioned previously, a strong risk for seizures to occur with rewarming. If that happens, again, it is associated with a less positive outcome. It is a little bit predictive of increased risk for death and or disability at 2 years. And as I'd mentioned, video EEG continues to be the gold standard. Oh, I forgot to mention that first-line treatment, for seizure activity is phenobarbital. There's a lot of debate in the literature currently whether other anti-epileptics will give better benefit in the long term, particularly Keppra. We often at UNM will start with phenobarbital, and then if there's need for a long-term anti-epileptic, we will usually switch to Keppra to go home on. And treatment does help prevent further deterioration and further brain damage. And so, as I'd mentioned, unfortunately, therapeutic hypothermia really does remain only the only treatment of choice currently. However, there are therapies that are experimental and have been done on animal models to try to get at some of these other pathways to see if we can help with disability. So in particular, EPO has been looked at as because of its ability to promote neurogenesis. It's an antioxidant, it's an anti-inflammatory, and it does seem to decrease apoptosis. Some of the heavy metals such as xenon and mag sulfate have been promising in their ability to block the NMDA receptor, and that is the receptor in the brain that seems to promote this excitotoxicity and the excitotoxic pathway by releasing glutamate, like we mentioned earlier. So they block that receptor. So maybe some promise there. Some of the endogenous cannabinoids have been shown to be neuroprotective. Gangliosides have also been shown to protect against apoptotic injury, and then stem cells actually can modulate the immune system. So some promising treatments maybe in the works, but nothing that is at the clinical level yet. And with that, I am at my time, but I do have a clinical scenario in here that goes through how we would recommend approaching that patient prior to getting the baby to the tertiary center. And so you all can go through my slides later and look for recommendations for initial management. And with that, I will open it up to questions.
Thank you, Dawn. That was great. I have one up here. They're asking if there has been a shown link between HIE and autism. Has there been any studies?
You know, that is a fantastic question, and I have not seen anything, but I haven't also looked. But I've done a lot of kind of deep digs on the long-term neurodevelopmental outcomes, and I've not come across anything. So, but that is a good question, and I am going to look that up.
Okay. See, I don't think I see any other big questions. Does anybody have anything they want to ask before we send Dawn on her way? All right, well, you guys have a 10-minute break and we will go ahead and see you soon. Thanks.